that way, depending on your patient. If it's a trauma patient, they're not able to stand, they have a leg injury, whatever. So you could do these same positions with the patient laying down. But I feel like, for me, I like to do it standing up. I feel like it's a little bit easier to maneuver the patient, rotate them, especially when you're getting into those obliques. So we'll start with the sternum.
Okay, so you know how in lecture I had questions about the oblique situation? I'm still confused.
We haven't talked about it yet.
Okay.
We left off right there. On Monday at lecture, we only did the AP and PA ribs for upper and lower. We didn't even get into the obliques.
It's just when we started talking about, I think you were saying oblique, and that was confusing me. I was like,
Oh, we did talk about the RAO for the sternum.
no, I think it's the rib. Like, I'm confused on the order, like the series.
Uh-huh.
And like, cause I know when to do the AP if it's, you know, posterior, and PA if it's anterior. But then when we started talking about how when you position them differently, it depends on the side for like the RAO or something.
So with obliques, it depends on.
I need a visual with it.
Yes, I think maybe what you're getting caught thinged on is I had referred to you guys a page in the textbook that explains the positioning of the obliques and the APPAs and why you do which one. So maybe you read that, but I hadn't actually verbally gone over it yet.
Okay.
But we will do that Monday, and I will touch on it today when I get into the oblique positions. Yeah.
Thanks.
And again, what I'm teaching you and we're going over in lecture, that's from your textbook because that's what you're expected to know, and that's what the registry is going to ask. Like when you go into clinicals and you see ribs, like you're going to see it like done 10 different ways. And you're going to see it done like not the way the textbook tells you to do it. So don't let that, don't get caught up on that. Just make sure you know the textbook way of how you do it and the reasoning and the theory behind it.
Okay.
All right. So sternum, since we're at 72, what do you think we should start at with the sternum?
The chest.
So not the chest. So we do the
with
chest.
The sternum?
Mm-hmm.
Say the lateral.
The lateral. So I'll start with the lateral. So 2 views for the sternum. You do your RAO and your lateral. So since we're at 72, I'll start with the lateral. The lateral is going to be very similar to just doing a chest x-ray, except you're going to move the patient back a little bit posterior because you want that crosshairs to be on the sternum anteriorly. And then you could collimate in quite a bit. The reason why we're going to 72 is the same reason why we do 72 for chest, because we're trying to offset that large OID we're going to have from the shoulder. You could use a 10 by 12 on the sternum. If you don't have a 10 by 12, it's fine to use a 14 by 17. You're just going to have to collimate in some. But the sternum, again, it's pretty much like the size of your hand lengthwise. So it'll definitely fit on a 10 by 12. If you use the 14 by 17, you could use the top of the receptor just like we do with the chest, put it 1.5 inches above the shoulder, and you'll have more than enough room to work with. There's 2 palpable landmarks that you can use with the sternum as well. You've got the xiphoid process on the inferior aspect, and then the jugular notch on the superior aspect. We usually don't really palpate the xiphoid process. Usually we just kind of go for the jugular notch or just get a visual from it, because most of the times you can actually see that depression there. So you could use those as well. Bezrat, can you dim the lights for me, please? Thank you. So I'm going to bring this down to make sure I'm lined up there. I'm going to go ahead and bring in my collimation. Now, for the sternum, you want the arms out of the way, just like we do with a chest. So you can either have the arms behind the patient back, and that's what most technologists will do, because when you put the arms behind the patient back, it's naturally going to cause your anterior region of your thorax to push out. All right, so that's kind of giving the sternum room to be separated from any other structures that'll be superimposed. So arms behind the back, or you can put the arms above the head. Either one's fine, but again, usually we like to do arms behind the back. I think your textbook shows the arm above their head. So either one works, just as long as they're out of the way from being superimposed in the thorax region. All right, so now I'm just going to make sure Miss Wallace is in a true lateral. I'm centering, again, anteriorly, so we're not going on that plane, okay, because we're not getting the entire chest. We want to be more anterior. And then we can angle the x-ray tube. We'll do that to go in alignment with the sternum, how it's positioned. I could close in my collimation a little bit more, and then I would put a left marker here, okay, because her left side's closest to the wall, Bucky, so I'll put my left marker there. And breathing instructions is going to be on suspended inspiration. So how my patient taking a deep breath in. Oh, I got it. Thank you. Taking a deep breath in, and then hold their breath. And that's going to help to protrude that sternum region even further out, so you can make sure you get it in its entirety. So there's my left marker. I'll have my shield on my patient, and that would be your sternum. You also want to make sure that you're not, the patient, like I see Miss Wallace has on a necklace, so you want to make sure, I'm going to open this up just a little bit. You want to make sure the patient has any jewelry, necklaces, all of that removed.
That's not too low. Or I'm trying to think of like where the sternum would actually be.
Yeah, we can bring it up a little bit. So this is how you want to look on Fred, how your arm's either behind or up out of the way, and then your sternum super anterior. So you want to make sure you're centering where the sternum will be.
Could you do it on Fred too?
Mm-hmm. I'm gonna have to bring this up.
So would you want to get like have the what? Like the clavicle of the because you do want to get the manubrium, right?
Mm-hmm.
So
So here's the very superior aspect of
Over there.
your xiphoid process. Mm-hmm. And then let's bring in our collimation some.
I'll go up a little bit more, Miss Hibbert, because it looks like we're cutting off the very top.
So you guys see it?
Mm-hmm.
I always used to use the shoulders. That's what I was saying. I'm saying you line up the top with the shoulders, because then you're parallel. Yeah.
You guys good with the lateral?
Mm-hmm.
Okay. So other view, RAO. So I'm going to bring my SID in to 40. How much are we obliquing the patient for the RAO?
15 to 20.
Uh-huh. So who gets what?
What you mean, who get what?
Like what type of patient gets 15, which one gets?
Oh, 15 is the hyperstenic and the 20 is the stenic.
Okay, everybody agree? Okay. So you want to make sure the differences and who get what patient size and patient body habitus gets the various locations. Why do we do a RAO as opposed to doing a different position?
Because it's, way. Put the heart to the left,
Heart shadow. And the heart shadow and the spine out of the way.
and it
So think about your spine, so you're offset and so on and so.
sort of appear to move over to the left.
Yeah, so you guys all, I was hearing all good things. So one, you wanna move the spine out of the way, okay? Cause naturally, the spine is directly superimposed with the sternum. So by doing that oblique, you're rotating the spine and the spinous processes out of the way of the sternum. And then the sternum, by putting them in the RAO, you're reducing OID. You're getting that part of interest closest to the receptor to reduce OID. And the sternum will fall into the heart shadow. So you don't have as many structures overlying that region to obscure it. Now you ideally still want to do an orthostatic breathing technique to help blur the ribs and the lungs out of the way would be ideal. So you want to have that long exposure, increase your seconds with your mask, and then have the patient continue to breathe during the exposure.
So you say do orthostatic breathing, because the book says specifically says recommends not to.
For the RAO,
It says
Yeah.
orthostatic technique is not recommended for erect RAO.
The thorax tends to move even during quiet respiration.
It's like a little asterisk at the bottom.
but
Ain't they
if
use
it's
them with
saying-
AEC?
But if it's saying the thorax tends to move with quiet respiration, that's what you want with orthostatic breathing. You want that motion to blur out those structures.
I don't know, that's what it says.
Oh, yeah.
Okay,
I gave
I'll,
it to.
oh yes, I have it in the office, sorry.
I'm gonna check and see, did it just change? I'm gonna go grab the
Oh,
remote.
okay, I think it's just on my desk somewhere.
I think I have another one.
Okay, well, we'll come back to that. And I'll also look at what the actual textbook says.
Okay, I'm gonna grab the green book to just see, cause that's the version before.
Yeah, but maybe they changed it. But if you're not utilizing orthostatic breathing technique, you, like let's say you have a patient that can't, follow instructions, or, you know, they're not gonna be able to actually adhere to that, you would just do the whole suspended respiration thing.
Because it's weird, because it says like do it and not to do it. So it's orthostatic breathing technique, like 4 seconds. Or suspended expiration, but then you go down here. And it says it's nothing.
What's the issue?
221.
So it's like,
No, I don't know what they mean by that, and like why they're specifying it for the erect.
right.
I don't know, we'll look into that.
Okay.
I'm not supposed to ask for that.
Yeah, that's
Um,
kind of weird. Yeah, it's like, you can do it, but we don't recommend it.
So RAO, so you want the patient's right shoulder should be close towards the board. Again, a shallow oblique of that 15 to 20 range, so you're not doing a full 45, just a little bit of a rotation. And then we want the crosshairs, remember we talked about this in lecture, it's gonna be off to the left a little bit. You don't want it to be directly on the spine because you're not examining the spine, we're examining the sternum, so we wanna get in the center where the sternum is. So that is gonna be off to the left by that oblique position you're doing. And then you can collimate, okay? So you can collimate in just to the sternum. I'm actually gonna, I think I wanna raise this up a little bit.
That's the edition before your edition. So the previous edition doesn't say anything about it.
Uh-huh.
Cause I remember I was like, I know.
They just added that.
But it like kinda contradicts itself, cause they were showing me at the top, it says to use orthostatic breathing and it talks about the 35 seconds and everything, but then it has that little asterisk and it has that weird comment at the bottom, so, and it just specifies for erect.
I get it, it's saying you can do that or the other, but then at the bottom, it's like, we don't recommend this one, so like.
Why, you know, I put it
Yeah,
there, I put it at the
yeah,
top.
like they're saying you can do, there's 2 different ways and this is the one we prefer.
So for testing purposes,
Well, for right now, I'm gonna go with the orthostatic breathing technique.
okay.
I'll try to see if I could, check with our graduates that have been taking the registry to see if that came up as a question on the registry and how it was worded and stuff like that. But we'll just use the orthostatic breathing technique. Or maybe, if we get the kettering material, it might be in there.
Go ahead.
That's why I was like, that's what I ordered. But clearly, and I wanna show you, cause I know I was just looking at this. That's why I said, let me go get this book, cause you know, sometimes my memory will fail me.
Mm-hmm,
It
Yeah.
says orthostatic breathing.
mm-hmm. Yeah. I don't know.
See, you know, I don't ask the people that actively
Yeah.
do this every day when they create these books.
Yeah.
It's not working for you.
I guess they have to say they made like some minor edits to get their sale values for the new editions and
Yes,
that
you
stuff.
have to have it, because there were some changes. And this would be the one change.
Here you go.
One asterisk
Thank
to
you.
confuse you.
All right, so I was putting my right marker there on the, and you wanna make sure that you put the right marker on the patient's right side, but close enough to where it's included in your collimation and it's gonna come out on your film, but not too close to get into the anatomy.
Where would you put this one?
Right where you were?
That was fine.
Yeah, that was fine.
I'm not seeing it.
Because of the shoulder. The
right
shoulder
shoulder.
blade is blocking it. Yeah, you may not be able to see it very well because of the other structures in the way, but the heart will like sit over here, cause your heart's on your left-hand side, so when you rotate, the sternum's gonna be right superimposed in that heart shadow, when you do the RAO.
And the orthostatic breathing would like blur the sternum a bit.
It'll blur like the ribs, and then the lung field will get blurred out.
So. We're not having them do anything with this arm.
Mm-mm.
Just
No,
shake
their
that.
arms will just be,
So they don't need to like put them behind their back.
I think you dropped some more, and just be careful
Oh.
with your head. Yeah, their arms will just be down at their side, you'll shield them, you're gonna bring the SID into 40, and that's pretty much it.
Okay.
So the tough thing with this position is that sometimes, usually you don't always get it on the first attempt, because, you might not have the oblique of the patient quite right, the sternum may not fall in the heart shadow, you might have spine superimposing, it may not get penetrated enough, so sometimes you might have to do a second one to adjust those things that didn't go as well with the first one. But the sternum is kind of rare, you're not gonna see it a lot. But it's not like a super challenging exam to do. I'm like, what is, oh, that's the lab test. Okay.
I brought those, but
Oh, okay. Is that stuff I printed?
this is some stuff I have.
Oh, okay. All right, so lateral and RAO. Any questions?
No.
Yeah, I was like, what time is it? Oh, it's 9:35. All right, let me go take a quick, I gotta step away for a real quick minute, but somebody, they could use Fred. I want somebody to position Fred and make sure you change the receptor for AP ribs, for the upper AP ribs. So someone do that. Do you need me to turn the lights on?
No.
No, SC.
Oh,
The who?
that's one of the.
Oh, sternum, clavicular? Yeah, it's posterior.
No, I was just.
Yeah.
curious.
Oh.
Let's ask her because.
The,
Do the ribs.
The AP ribs.
how she got the receptor in, Angel?
So you doing, one on?
We're doing the, upper, the above the diaphragm.
But it has a
I mean, after I figure out what I want.
It got bilateral, so you just show.
Yeah, she
You don't
told me
know,
when I got
you
it.
don't need lateral.
Yeah, they thought
put
it
it
all
above.
taken every year, like,
The other program.
mhm.
Don't want-
I'm
don't want
assuming
them
because
right
they
here. Oh.
can kind of.
It's weird, like at the VA, it looks a bit closer.
The James guys are super chill, so it's fine. There's like a mentally ill patient like right across the hall that's been for like a month, so she screams the whole time, but other than that.
She's in the room?
Yeah, cause I guess like she was in a group home and they just like abandoned her at the ER, so,
And they won't give her a room on the floor?
you know. I'm assuming so other patients can sleep and the ER is like kinda running all the time, but,
That's weird.
yeah, it's sad, but, you know.
So what can you do? What can you do? Since we have Fred up there.
What now? What you,
What
Bring it
additional things?
down
can you do?
more.
So you're doing the AP,
Count the
right?
breathing.
You're breathing?
Suspended embedded inspiration.
And we can call them there.
mm-hmm.
You can see. you can-
With Fred, you can.
You can come in some more, right? Cause you see, yep, there you go.
How many pumps do we need this
Oh,
semester?
yeah. It's a shorter semester.
So let's talk a little bit about that because I think it was 10 or 15. And I don't have my computer on the board. We'll talk about it.
See, and that's the thing, we have to kinda pick and choose.
But,
Which
I mean,
pumps?
we're not gonna penalize you based on the site, because you know my plans were to leave you guys at the site for the entire semester. Yeah. And I changed it for the sake of, if you kind of positive about it, so I adjusted the change. And you know we're doing 200 hours, so those of you who are at clinical sites, where you might not be able to get that, i.e. I'm gonna figure out some things you can do that will be offered to the entire class. That will make up that difference, okay? So don't stress about that, but it'll be offered to the entire class, okay?
$5. Cause like, I stayed till 5 on Tuesday, but that whole last hour,
Y'all were doing.
nobody did.
Where are you?
Showa,
Yeah,
Oh,
it's really nice.
it is.
What other, cause I stepped out.
They have games that they'll give to the kids.
We just did the sternum.
Did she do a double oblique?
Yeah.
On what?
Sternum, yeah, she did. a lot,
She
yeah.
did the sternum, the lateral and oblique,
She did the aria.
RAO and, lateral.
Okay, somebody wanna do an LPO?
On which one?
Oh, Fred,
On what?
ribs.
Who's on?
I have to send
'Cause
you
I'm
paper
recording.
for that clinical is the fact that it's only 30 minutes.
Who doing it? I'm recording, y'all.
So what I'm giving you guys, remember I told you I would start working on those positioning books and I was gonna give y'all some images? I'm giving them to you in small spurts.
I don't even remember this anymore. No, I'm just kidding.
So this is your next set and then I'll go back and fill in from where we left off for the upper and lower extremities. But I thought it'd be good to give you the soft tissue neck and ribs now. So as you're creating your book, you wanna make sure that you are
You gonna go do the
doing the
LPO?
central ray and anatomical regions, okay?
She told y'all the
Do
position.
the LPO. Oh, let's do the lower, angle, and then we'll do the upper. So we did the upper ribs, so position Fred for me, Angel for the lower ribs.
Why are they switching the phone down?
I'm sorry, excuse me.
So what's the landmark? for the
It's,
lower?
you wanna go, midway between, probably lower than that.
The,
Lower than that, like you.
the lower costa ribs and the, iliac crest.
Yeah. So like in this
Halfway
vicinity.
process and lower rib region.
aiming through, you're aiming for this
You
area,
don't
so
go-
I would be in between here,
Yeah,
so it'll be an overlap.
yeah.
Oh, so it is overlap, okay,
Mhm.
okay.
Cause you don't need all this, you don't need to see all that.
I think it's just the way I see the image.
Midway, it say midway between xiphoid and the lower marginal, lower rib margin.
So this is the lower rib margin, so we're halfway.
What's the lower rib margin?
Look where you feel the.
Oh, the 12.
Yeah, where you feel the floating, so xiphoid, halfway. Cause just think, you have 1, 2, 3, 4, 5,
Mm-hmm.
and you wanna make sure it's overlapping from 5, so now you have 6, 7, 8, 9, 10, 11, 12, cause this floats, it doesn't come all the way around.
Yeah, okay.
Any questions about that?
Do it again. Cut the light on, Angel.
Did we do all of our red views at, 40 or 72? What, SID do we use?
Hold on, I'll tell you.
72 or right
40 is their recumbent.
These are things you guys need to remember, okay? So when we're doing the lower ribs, which ones are we focused on?
The last,
5 through 12.
the false, the floating.
You wanna make sure you at least get 10 through 12, okay? Angel, you enjoying being up here, do the LPR, just do the L,
I wanted to
you wanna say? Okay,
Yeah, somebody else get up here.
come on, Nadia.
I've done 2 of them. And I'll set the room up. I'm doing all of those today, though.
So when you, are you guys actively working on creating that flip chart? Or do you
Not
do
gonna
it?
lie,
Okay, some of your very.
because I needed images.
Okay, but did you use the last ones that I gave you? Cause I gave y'all what's that a while back, it was the hand, the foot, Bezrat, remember right? Ms. Clark, you remember right?
What?
The images I gave you guys.
Yeah, you did give us some images. The foot, the
I forgot that was for this. I have one, but I
So
just,
start making your flip chart, if you wanna set a section up for upper, a section for lower, and a section for, chest and thorax, and put your soft tissue next, so the first.
So what were we doing with
This
this?
is your soft tissue next.
What's the landmark?
it's up
This is your
more
chest.
than that.
This is your decubitus.
Yeah, 'cause you at the xiphoid
This
process.
is your oblique.
7 to 8
I don't
inches.
know what the landmark is.
7 to 8 inches below the vertebrocolumns.
Decubitus, and you said this is.
Right there?
Your oblique, so which is left and which is right.
Pretend this way. So they
What
consider,
is below the,
that's a,
Aria.
Which one you doing, LPO?
yeah,
but how?
what is that?
It's about.
Top is
How?
So when you're,
It's not an
so
elbow?
your oblique, so which side is elongated? So if I'm up against the bucket.
The heart is.
Oh, for the LP, oh, that's the lower.
Say L on them.
That's the upper.
No, it's on both of them.
Upper is,
No, but the left.
yeah.
So you know when you're
Oh,
doing
I
your
had flipped
oblique,
the
the side
page.
that's short represents the shallow, that's oblique. The other side
No,
that's
that's
out
it.
is your elongated side.
Mm-hmm.
So
So
the
wait.
left side is closer to the bucket. No?
Everybody see this, cause I'm gonna position myself,
For what?
I hope.
What you positioning yourself for?
so y'all can see the images there.
Okay. Well, I'm just getting Fred real good.
Everybody see it, Bezrat, you see this, what position is that?
Which one, this one? LPO.
Yes, that's your left posterior side is closer to the bucket.
Angel said she tired. What you calling her for? Oh. Oh.
So what, I'm gonna move, let me do it with Fred.
Okay. What you doing with Fred?
You're elongating the side that's away.
Mm-hmm.
So the side that's shortened is the side that's closest to the receptor.
So that's just a L.
RAO. That's the RA. That's the
So my
L.
right anterior
This
side
side.
is closest to the bucket.
Mm-hmm.
So my left side is elongated.
for the
See
RAO.
that here and then I look here and I get confused.
So that's why I want, elongated side
Is away from.
is away from the bucky.
Cut the light on, Nadia.
then do I have these backwards? Elongated side is away.
So if I do this, what is this?
LAO. And the elongated side will be the right side,
So the elongated side now is my,
right side.
Right side.
Yeah, right side.
That's what this one.
That's what?
Yeah. What she's doing right now. Right.
So LAO?
so my left
Uh-huh.
anterior side is closest to the bucky, so my right side is elongated.
Okay.
Y'all got it?
Mm-hmm.
And we're gonna flip it around.
RPO.
This is a what?
RPO.
So my, do I need to? Okay. Am I in the center?
Mm-mm.
I'm not, I need to move for it, I'm sorry, you know, but this is alright.
Okay.
So then when I do this, I'm doing a,
LP. I mean, lateral.
this
I mean-
is a,
LAO.
Yeah,
and which side is elongated?
Right.
right.
So let's do, I didn't do the RPO, did I?
Yeah,
Did I do all of them?
you just did, I think. Do it again.
Okay, let's go through them again, so then I'll let y'all practice, because I know it can be confusing, that's why I wanna do it with Fred, so y'all can physically see the bones,
Okay,
So and then I'm gonna ask y'all some questions
okay,
about what you're gonna do based on the patient presenting themselves to the ER or wherever, and you're needing to see the area of interest.
okay.
Alright, let's start with our anterior one. So this is
LAO.
this is a what?
RAO, I'm sorry.
RAO, don't confuse about it.
RAO.
Somebody snap a picture of this.
Mm.
Somebody put this in y'all group, so y'all can physically see.
Where my phone at, y'all? Wait a minute, Nadia, hand me my phone.
Alright, label it Bezrat.
Let me see the phone. I'm gonna take pictures too.
I'm not in that group chat.
Thank you.
Put it on Remind. Everybody on Remind, right?
What's remind?
I deleted that because we used it one time, so I was like,
Okay.
this is
Taking up
space.
Well, you guys can send them to me, email them to me, and I'll email them out to the class. The pictures, because I want y'all to have this. Because this is gonna help you remember this,
I
okay?
think, you might wanna take the picture like more straight on, cause it's sideways.
Turn the light back on Bezrat for me.
Yeah.
So this first image that I have Fred in is a RAL. So you're gonna label that image, okay?
Left side's elongated.
You labeling? Okay, keep going.
So now I'm gonna do a L.
Wait, quick question. So when we're looking at the image, elongated, it's the width or the length, like the width or the length?
It's the ribs that we're looking at. So this is,
Looking at the long.
see, do it based on the ribs, cause it's,
See how long these are, and then see how
This
short
is short.
these are.
don't fall, Angel.
You see, like,
So
there's-
this is short, cause I've obliqued it, it's not
see.
straight on, but you've elongated the opposite side, and the elongated side is away from the bucket, long away,
Okay,
okay?
long, okay, got it.
Maybe
But
put that
then
on there,
those
long
these
away.
Long, so these would be considered. Oh,
You see it
I
now?
see, no, cause I see it comes all the way
Yeah.
up here, I was just looking at here.
Nadia, take
Got it
notes,
now?
girl.
Okay. So now we're gonna do a LAO. And now I have my right side is now elongated. Alright, somebody take a picture, make sure y'all label that. Make sure y'all email these to Ms. Wallace so I can send them to the, well, I feel like we left something out. We did the upper and lower AP, and we did the obliques. And normally you do a chest.
These are ribs.
For the rib series, you
For
do
the
the
rib
chest.
You do a, chest as well.
So this is,
So now we're gonna do our posterior obliques. So this is a. This is a,
RPO.
this is a LPO.
LPO.
Nadia, come help me while this out and hold this arm out there. So what is elongated?
the, left side.
The same side.
So what view does this replicate? Cause you're only gonna do two.
That's an RPO.
Okay.
RPO
So did y'all
represents
label that?
LAO.
It's just reversed. Thank you. I feel like I don't have Fred close enough.
We don't have like a separate set of pictures.
Bring them
I
over
did not.
some.
So,
I did
Bring
not do a
them
separate
over.
set of pictures. This was a.
Yeah.
This is a LPO.
we don't have like the PO picture.
I did not, yeah.
Cause it's not as
Mm-mm.
common to do it that way, right?
So most times they're gonna do.
That's
one of these.
RPO.
That's the RPO.
Yes, what I said.
L.
I'm sorry.
RPO.
Yeah, this is,
RPO.
sorry. I'm
Which
sorry.
is the same as
LAO.
Yes.
Okay.
So I'm answering too many questions. No, I did not, because I didn't want to confuse you guys.
Okay. But is it okay if we prefer the POs?
Yes, so do y'all want me to print out POs?
I prefer
I
PO.
prefer it.
I
Okay.
find it less confusing than AO.
Okay, I'll print out POs and make sure Ms. Hipper give you guys them on Monday.
Okay.
Matter of fact, I may have time to go to my office and do it before you leave.
Okay.
It's okay. It's okay.
All right, so now we're gonna do the,
LPO.
and now, let me get my arm out of the way.
LPO.
Any questions? So, there's the 2 sternal views you wanna practice, and the 3 rib views.
Which are the
You're gonna do
AP.
a chest,
chest.
and you're either gonna do a
P-
LPO
PO.
or a RPO,
PO.
or, yes.
Upper
And then the
below.
upper and lower, so 4.
Um,
No, 5. Certain places have 5. They'll do a AP, upper, lower,
AP upper and lower.
Mm-hmm.
maybe a 6 then.
So wait,
Chest,
So they'll do a.
AP upper,
Chest.
AP lower.
Mhm.
AP lower,
And your
AP.
And then your obliques, and you're gonna do
OP.
2
OP.
obliques,
upper and lower. So that's 4.
based on the patient's body happiness. Certain patients, you can include all 12.
Certain you can't.
Certain patients, you're gonna have to do upper and lowers for your obliques as well.
Okay.
You could do 2 obliques for each.
12 would be if they're like.
So it's
looking at
basically,
all the obliques.
Upper and lower
That's the other
oblique.
reason why we do 72, because you get that distance, and it can eliminate the amount of view. Don't hit your head. please.
I'm not. I feel it.
Right.
I feel
Right
it.
there.
I feel it.
Please move.
I'm not gonna hit my head.
I'll
Well,
feel
it's
that.
like touching, it was touching your hair.
I knew. I felt it.
So you could have to do,
So all ribs are 72,
yes.
and
Unless
the
they
lateral,
recover.
unless they recover, and the lateral sternum is 72, and the RAO is 40, and everything on the table is 40.
But
Okay.
it's easier to do ribs standing.
Standing.
You don't wanna lay a patient down that has injured their ribs and try to have to help them get up.
Yeah. Did y'all? I don't.
So to
the only-
break to practice, okay?
How about I seen a table, you guys, at Southern Regional, in their for the rooms they do for ER. They are remote control.
Oh, yeah.
They're like that.
Yeah, if it,
I-
it's like that.
Yeah, because the other
It's
rooms,
automatic.
yeah, the other rooms are cassettes, so I done use the cassettes. I done use both.
Y'all know,
And the
I was
portable.
halfway through the recordings. I'm probably gonna send y'all the recordings for the film screen, but I'm gonna take the opportunity to finish that lecture on that daily cross section on that.
Okay.
And we'll also review the quiz,
Okay.
okay?
I'll take all the virtual learning I can get.
Cause gas is too
I
high.
was just gonna say gas is going up again.
Boy, it done went up again.
Y'all, can it stabilize?
No,
To
they,
make it as long as that war stuff is going on over there.
It's not gonna
We're
stabilize.
not getting any more money, nothing, food is going up, everything is going up.
Yeah, as long as that's going on, it's gonna stay high.
Quick note for what I want y'all to be doing for this, and I'm gonna have y'all,
hold on.
for the spring, I'm gonna have y'all bring this in, because I feel like I'm doing this and ain't nobody doing nothing with it.
I'm gonna get a glue stick today.
So make
Look, I got
sure-
some at home.
You're putting the actual view, the patient, position, and where the central ray enters.
You write that on the side,
We mean,
somebody.
What do you mean
side.
patient view?
what's the difference between the patient view and the view in the projection that we're doing?
So the view, tell me what the difference is.
For which one?
Like
What's the difference?
upper, lower?
Yes.
Okay.
And tell me what anatomical regions are visualized. But this is gonna help you
They're not gonna
You
fit.
writing that down,
on
Nadia?
the registry.
Wait. View,
Oh,
So what-
Jesus.
So you would say, so let's go to the soft tissue neck. This
Wait, you
is
said-
a soft tissue neck,
position.
and is the patient in the AP or PA?
Projection, patient.
AP.
AP.
Okay. What anatomical structures do I see?
You gotta write all of them,
The cervical vertebrae?
And what else?
You see
The
the
first and second rib?
clavicle,
The,
the
okay.
first rib,
And then where does where do you put your central ray?
for what, the,
This view.
for a soft tissue neck,
for soft tissue neck,
like the middle of the.
if you erect, I know, I seen Miss, Grant goes into the mouth.
What,
She
Not for
opened the
soft
mouth.
tissue neck.
what is the point of the soft tissue neck? Like, why wouldn't you just do like a cervical spine?
So if
Adenoids.
they've swallowed something and you wanna try to see where it is,
Mm.
or the adenoid.
Oh, yeah. They said that yesterday at Joe, or
Mhm.
Tuesday at Joe.
They do a lot of
Because
soft
they did a
tissue.
soft tissue. and I was
They do a
like,
lot
why?
of soft tissue neck
Wait, what is
there.
it? Patient position,
I've
let's
never seen
visualize
that.
in the image in the CR location. I feel like I'm missing something else.
Patient, the view, upper and lower, something about the view.
Tell what the view is. So this is a lateral soft tissue neck. So when I ask to see this, this may be extra points towards your radiation protection, okay? That's gonna be your class in the fall. And I'm gonna,
Is that
anybody
when
write
we are
this down?
considered seniors?
yes, y'all become seniors at the end of this semester.
I thought so.
It's scary but awesome.
See, that's why,
I'm
you
so
know,
ready to be a graduate.
see, that's why,
Just jump past.
now I understand them seniors much more, because,
I still don't understand.
well, they was giving the, juniors a bad rep, but they only had 2 semesters of clinicals. So I kinda get,
We had
You
2
mean-
semesters of clinical.
at that time when we became juniors,
Oh, you're saying the time that they had been in clinic was only 2 semesters before they became a senior.
mm-hmm,
So let me, I'll kinda get, show
and
you what I'm talking
clinicals,
about.
2
I want you to-
semesters of clinicals, before they became a senior.
Yeah, you can still like
That-
show
that
up
ain't
on
what
time
I'm-
and work.
That ain't what I'm saying, I was just saying, that's why they was saying that.
Oh, okay.
Yeah, I'm not
That's not what I
saying,
heard.
Yeah,
We heard some other
That
things.
doesn't-
yeah, they were like,
Nothing to
that
do
girl was
with-
doing her resume, and I was like,
nah, they, what I heard was that they didn't know,
AP soft tissue.
um, certain positions or what to do with the position or whatever.
Well, by the time you
It
get to
wasn't
this
about
point,
them being
this is
late.
the last position in class. So this is basically what y'all are gonna be doing.
Can you put that on my phone? Can I see that on the,
someone make them?
can I see that?
Hold on.
This is a resource that I'm gonna purchase
Can
to
you,
have on
can you
campus
just
for you
send
guys.
that picture?
Wait a
like,
minute.
Whenever you talk about what we're supposed to be doing for this assignment, can you use this extra credit, like just,
Is my finger in the way?
This is just,
Hold on. Be still, Miss Wallace.
there's 2 of those, so I don't know.
Hold on, let me put it on the camera.
It's
See,
the
these two have
same.
labeling.
The light is in the way.
So one of them with the red.
This is
But no,
lateral.
it's, we
So
need,
this
like-
would be the ribs, because it's less contrast. And this is less biopsy, but it's
chest though.
Yeah,
Yeah,
chest,
we
right?
turn on the lights.
Wait a
They,
minute.
so I had printed some images out of some stuff that we had done and what we were starting to do, and we were going over that when they finished this curve. Oh,
Let me turn on the
are
lights.
we gonna adjust the amount of comps that they have to do for this, clinical rotation?
No, as far as increasing it?
Or decreasing it, cause I think a lot of them went over the amount last time.
I wouldn't get as many.
I think